Well, good afternoon, everyone. I have 12:05 or 1:05, depending on the time zone that you're in. Again, my name is Ashley Green, and I'm a quality improvement specialist at Metastar in Wisconsin, and I'd like to welcome you to the kickoff webinar for the Improving Cardiac Health and Reducing Cardiac Health Care Disparities Learning and Action Network for the Lake Superior Quality Innovation Network. I'm going to go ahead and mute all.
Your line is now muted.
Just because that's a pretty good practice as folks drop in. We hope we'll have a few more join us over the lunch hour for a couple of the states here. But just by way of kind of a quick introduction, I know that many of you who are going to be working with us are aware of a new brand that's being floated about for the Medicare work. And to those of you who we have not recruited yet for the work, this may be some news for you as well, but there was a recent change in the contracting with the quality improvement organizations in our respective states. To make a long story short, CMS had a number of the QIOs regionalized. And so we are here today as the Lake Superior Quality Innovation Network, which is a partnership of Metastar in Wisconsin, Stratus Health in Minnesota, and Impro in Michigan. And so this is really an advantageous arrangement because it allows us to collectivize a number of the resources that we would otherwise be using individually with the practice we're working with. So very quickly you can see that there are a number of other new QINs across the state. And of course we have partnerships with those folks and friends with them as well. And so there's a large pool of tools and resources that we can tap into as we do this work together. Now, one of the nice things about this arrangement with the three states is also the fact that we are fully funded by CMS through July 31st of 2019. So the way to think about this is that you've got us locked in for the next several years to do this important work, and so we're eager to get that started. A number of the initiatives that we're working on in this new, what CMS calls scope of work, you'll probably hear us use that term sometimes, are listed here. You can see that we are not merely focused on cardiac care. We also do a lot of work with the other things listed here, diabetes, immunizations, of course meaningful use. There's still a great deal of work to do, care coordination, so building community coalitions there, quality reporting. There have been a number of changes, and then some work with healthcare-associated infections and healthcare-acquired conditions in nursing homes. So we work very closely with our other colleagues within this much larger contract to really make an impact in the health outcomes of the work that we're doing. So a couple of things that we want to accomplish here on this introductory webinar are listed here. Now, as part of this new Learning and Action Network that we're launching, there will be a variety of programming developed over the coming months and years. We certainly look forward to some contributions from you as well. Again, I'll note that some of you on the call today have already agreed to work with us on this initiative, and some of you are perhaps prospective or learning about this for the first time, but a hearty welcome to all of you for joining us. We're going to talk a little bit about the context for the work that we're doing in cardiac health, describe some of the key goals of an important national initiative known as Million Hearts, which you may be familiar with, talk about our relationship to the home health agencies we're working with, and delve a little bit into our TeamBased Care philosophy, which is incorporated into our technical assistance. So I'm pretty confident that I'm preaching to the choir here. I just kind of wanted to sort of bring into our awareness again the prevalence and the extent of cardiovascular disease. We're talking about with regard to heart disease, the number one cause of death in the nation for a number of years going now, and stroke, or think of brain attacks here as being the number 4 cause of death. These are problems that persist. They are compounded if you are a patient in an underserved community, and that's going to be a dimension of the work that we do together over the next several years. So that's important to point out as well. So while we've seen a gradual decline in mortality probably over the last 40 years or so, it remains the leading cause of death. And in fact, each year more than 2 million people will have a heart attack or stroke, and 800,000 of them will die. It's the leading cause of preventable death in people under the age of 65. And as if the cost in human lives and suffering was not enough, the trauma to families and communities is devastating economically. We're talking about $444 billion every year. That's more than $1 billion each day in medical costs and lost productivity. And of course, in a highly developed nation such as ours, it's almost unconscionable that we would continue to have great disparities in the care that's provided to communities around the country. And I apologize, some of these may be a little bit difficult to read depending on the size of your screen, but you can see some pretty impressive statistics here. So with hypertension, there's a higher prevalence with older adults, especially in African American communities, those in lower family income brackets, lower education. Generally, any socioeconomically stressed community is going to be faced with kind of a double issue here when it comes to things like coronary heart disease and stroke. There is a higher death rate before the age of 75 for African American women than Caucasian women, and for African American men than Caucasian men. There are a number of things that we can look at here, and I don't want to delay our discussion of our work, but again, just one final slide that sort of illustrates, I think, the disparity. If you're partial to bar graphs, you can see here that it's especially concerning when you look at the hypertension figures here from 2006. Non-Hispanic black persons were more likely than non-Hispanic white and Mexican American persons to have at least one of these 3 conditions, whether diagnosed or not. So we have a big needle to move here with regard to these problems, and so that brings us to our discussion about the work that we're going to be doing as part of this important new initiative. So broadly, we have a threefold goal for the program. The work that we're going to be doing supports the National Prevention Strategy and 3 of its core strategic directions, which look at promoting community preventative services, empowering folks to support healthy choices, and eliminating disparities. So a lot of our work centers on evidence-based best practices that we can implement in your organization, supporting the Million Hearts Initiative, which I'll get into here in a few minutes, and improving cardiac health in underserved communities. And to be clear, we're not only talking about racial and ethnic communities typically in an inner-city setting. Rural settings can be equally as diverse and suffer from additional problems there. So rural communities certainly fall into the category of underserved in a number of cases. So that's largely the task that CMS, or the Centers for Medicare and Medicaid Services, has outlined for us. And of course, those of you that are familiar with quality improvement initiatives kind of understand the maxim that to make a change, you first have to be able to measure the problem or the intervention. So without measurement, it's difficult to gauge how successful we've been with the interventions or the changes that we've made. In a couple of minutes, I'm going to talk a little bit about what we call the ADCs These are 4 measures that make up the Million Hearts Initiative. But for this work with CMS, there are 2 principal measures that you're probably aware of. Blood pressure control, or for those of you who are, like me, quality measurement nerds, those are numbered in the PQRS program, number 236, and for smoking cessation counseling, it's PQRS 226. Now, I have a note here. For those of you who are already going to be working with us, you know that a big component of this is the electronic reporting of these measures. That's not a deal breaker for those of you who don't do that, because CMS likes us to work with as many folks as we can in a meaningful degree. So don't let that ideal footnote there necessarily dissuade you from working with us in the future if you've not already agreed to work with us. But you can understand what's a trend towards electronic reporting, especially in programs like Meaningful Use, why there would be some interest in using those national programs to assess our success over time. Now on to the Million Hearts Initiative, a little more substantive here. This is, for those of you who are not aware of the program, a 5-year national effort that has been co-led by the Centers for Disease Control and CMS. The clock began ticking January 1st of 2012, so we've got about 18 months or so left in this national initiative, and it really kind of sets forth this audacious goal of preventing 1 million heart attacks and strokes by the conclusion of this initiative. It's audacious because we think it's achievable only with the collective efforts of all of us at varying levels, whether that's in a federal agency, at the state level, regionally like we have in Lake Superior, communities, individual efforts. It's going to take a lot of improved synergy among all these parts to really move that needle in the direction that we want to go. So there's a lot of work left to do for Million Hearts. It is an initiative that has a number of components. It kind of takes a 2-pronged approach here, and this is consistent with the work that we'll be doing together going forward on improving cardiac health and reducing cardiac health care disparities. Yes, indeed, there is a definite clinical focus, especially on beneficiary care, because we are employed by CMS to do this work. Health information technology, so the implementation of electronic health record, that's a resource that has a significant role to play in this work, of course. A lot of you already realize that from your work on the EHR incentive programs. There are a number of clinical innovations that have been developed, but the real issue there is sort of spreading them to organizations who are either unaware of them or not confident in their ability to implement those. And so that's going to be a big part of the work that we do together. Now, our work is not merely reactive. It's not just focused on clinical interventions. One of our sort of marching orders with CMS, and I think just good science here, is a more upstream look at a number of the factors that to the diseases and the systemic problems that we are having with the cardiac health, especially of underserved communities. So there's a great deal of work that we can do there, if not always directly, oftentimes in conjunction with stakeholders. And so in working with Lake Superior QIN, you have access as a practice to those relationships that we have. And it's a way for us to amplify your voice and your ideas and to understand your own broader community a little bit better and where we can help with that continuum of care that you provide. We know there's a great deal of work to do there. And so this certainly has a population health component. You probably know from news reports recently, the FDA has issued some new regulations on trans fats, and we're certainly concerned about food deserts in a number of communities and access to basic care. And wherever we can, we want to augment our clinical work with action in the larger community. And certainly we listen to your voice in that regard. So back to Million Hearts. Again, this is an important initiative to bring up because it provides some of the context for the work that we're doing. So the four pillars, if you will, or that create the foundation for this initiative are the ADCs, or the appropriate aspirin therapy, blood pressure control, cholesterol management, and smoking counseling and cessation. Now, all four of these are important as far as the reduction of stroke and heart attack in the nation. In particular, on the four, we're going to focus in our work on blood pressure control and smoking cessation counseling. Now, what's interesting about these is not any kind of rocket science. This is old science that clinicians have been probably painfully aware of for some time. These are some of the biggest risk factors for heart disease. In fact, from a 2008 National Health and Nutrition Examination Survey, almost half, or an estimated 100 million U.S. adults over 20, have at least one of the following three preventable CVD risk factors: uncontrolled hypertension, uncontrolled high cholesterol, or smoking. These are simple, though not easy, but preventable diseases. And in our work together, what we have here in the ABCS is kind of a simple, uniform set of measures, the data for which are collected in the workflows that you do every day with your patients in the clinics. And one of the things that I want to point out, I realize that we do the work that we do because of the patients' lives. Those matter. But there's also a financial return on investment for the work that you do. As you well know, there are a number of federal programs. The EHR incentive program being one of those. Whether you see a number of Medicare or perhaps Medicaid patients, you're aware of the electronic clinical quality measures that your providers and organization need to report on as part of the progress you're making. Certainly the physician quality reporting system folks know about. HEDIS, which is more of a commercial sort of evaluation for this work. Either way, our culture of pay for reporting that we've done up to this point is definitively shifting to a pay-for-performance approach. And if you haven't heard of it already, I'm sure you have, you certainly will be soon, the value-based modifier, which is value-based payment, is a program that CMS has instituted sort of on the shoulders of PQRS, and it provides either a bonus for higher quality work or a penalty for lower quality work as measured by sort of the nation's median progress in these areas. So it definitely behooves us to think about how we can improve our care over time, not only for the benefit of the patient, but also in terms of the payment system that's being developed by the government. All right, so what kind of work are we going to be doing over the coming months and the next few years? So I have to say at this point, standard caveats apply. I and my colleagues in Michigan and Minnesota will say that any technical assistance strategy we develop with a healthcare organization will always be tailored to your specific needs. But here are some of the sort of key ingredients that you can count on. I've mentioned best practices, so there is evidence-based medicine that has been used very successfully in certain settings, and so one of the bigger issues is just raising awareness and helping folks implement those new practices. For example, with Million Hearts itself, there are a number of resources listed. There's a cardiac population health toolkit that you may or may not know about. The Home Health Quality Improvement National Campaign, I'll talk about that in a couple of minutes. There have been additional resources identified by the AMA, the American Heart Association, and so on. There are a number of really valuable approaches out there that you can implement, but you may need some help navigating all of that, and that's a service that we can happily help you with there. PDSA cycles are a fancy way to say, try something. If it works, keep up with it. If it doesn't, drop it and adopt something else. So this is a plan, do, study, act cycle for those of you who are aware of QI terminology. The TeamBased Care model is certainly a big component of this. As we work together, we've begun to realize that more finely tuned teamwork results in healthier patient outcomes. It helps us to realize a number of efficiencies, save money as a result, and leads to greater patient engagement and satisfaction in the long run. But that's not easy work, and that's something that we can certainly help with. I've alluded to our interest in the community setting. Certainly our work with stakeholders and connecting you to those stakeholders and the work that they do is an important part of this. We'll talk a good bit about culture change over the coming months. Again, you'll hear me say sometimes this is not rocket science. It is simple, but it's not always easy to implement. And so sometimes you can benefit from kind of an extra set of eyes or hands in some of this work, and that's work that we have done for years now and been very successful with. So you'll start to hear things about team steps, which is a way to sort of implement a team-based approach to care. Motivational interviewing is certainly something that has a great interest base in the healthcare community. And then, of course, the ever difficult, how do we engage our patients? How do we keep them motivated, adherent to these wonderful science and evidence-based protocols that we've developed? How do we help them engage in their care? So there are many, many more things that I could say about this, but these are just some of the areas of potential collaboration. Now, within that, there is a definite focus from the CMS point of view on blood pressure. Blood pressure is often regarded as kind of a silent killer. What makes it so difficult is the fact that often patients don't exhibit symptoms or pain that would illustrate to them that they do need to get help. And so the proper evaluation of blood pressure is critical in the work that we're doing. You'd be surprised at how much work there is to do in this area still. The use of protocols, which, depending on your preference as an organization, may or may not be the best fit. We have worked with both kinds of organizations, a number that have implemented these very successfully, others that have tried a little bit more of an organic approach. In terms of maximizing treatment goals, we'll look at the guidelines established by the Joint National Committee, so the JNC8 measures that have been out, which provide us with a number of goals based on demographics, things like race, age, and chronic disease. And as I've mentioned, sort of empowering patients to contribute to the management of their own care. And really, if we're honest with ourselves, this often includes engaging the larger family as well in a number of cases. So working directly with beneficiaries. And by the way, we will be inviting beneficiaries to this Learning in Action Network as well. So we'll be able to get some direct feedback from them And certainly we'd welcome any opportunity to meet beneficiaries in your communities that may be able to contribute to this larger network as well. Now, I kind of mentioned that proper assessment of blood pressure is a big focus as well. So the irony is you'd think that in one of the most commonly performed procedures in clinics across the world that we get this right. Yet the value of an accurate blood pressure management is usually undervalued. So even the smallest inaccuracies can have considerable consequences. So a statistic that we found recently said that underestimating the true blood pressure by 5 millimeters of mercury would mislabel more than 20 million Americans as pre-hypertensive when in fact they're actually hypertensive and should have that diagnosis. So one of the services that we offer in consultation with our clinical partners and advisors is a refocus on proper assessment. We have training materials that can help with this. It's surprising how easy it is to take these inaccurate measurements. Patients are hurried, the medical staff is hurried, cuffs aren't fitting quite right, folks are talking, maybe their legs are crossed when they're setting. There are all these things that can contribute. But another way to sort of look at this and to sort of situate the importance of proper assessment is this statistic here. So for that same 5 millimeters of mercury, if in fact the person was hypertensive and we had an accurate measurement, reducing their blood pressure by that 5 millimeters of mercury would result in a 14% reduction in mortality due to stroke and an almost 10% reduction due to CHD, 7% decrease in all-cause mortality. So you can see that even the most seemingly insignificant procedures that we undertake every day can have sweeping impact on these communities that we serve. So anyway, this is an important component of the work. I've alluded to the fact that team-based care is of significance to us. There's certainly a national trend in this direction. The evidence bears out why it's a good idea to work closely as a team. Better health outcomes are in evidence, as well as savings of money, stronger patient engagement. Now, we also recognize there's no one-size-fits-all approach to team-based care, but CMS is a big proponent of this. Other stewards of quality, like the NCQA, whose PCMH or patient-centered medical home accreditation rely on this, also recognize the value. We recognize that it takes time, so this is an area that we will likely place some emphasis on as we work with all of you. In fact, we're fortunate in the Lake Superior QIN to have a clinic in western Wisconsin that's a 2-time national Million Hearts hypertension control champion. They've been recognized a couple of times, and they consistently have blood pressure control rates in the high 90s year after year. And they went through kind of a painful evolution of this team-based care approach, and they really shifted their thinking from a more traditional physician problem view of these issues to a team challenge view. And in really empowering the members of their team, whether that's nursing staff, medical assistants, care coordinators, even frontline staff, they've been able to realize some significant improvements. And we hope to share their story with you in the coming months as well. So there's a great deal that we can do with that. And I, of course, mentioned team steps and motivational interviewing trainings that we'll be offering in the upcoming months as well. Now, while we're on the issue of, or rather while we're on the topic of team-based care, an important component of the work that Lake Superior is going to be doing here over the next couple of years involves home health agencies. And so CMS has really embraced this broader view of what it means to be a team. So the team is not limited to those providers who are in the clinic. Without a doubt, it involves additional players that are found in the communities of those patients and also their homes. And so some of the work that we're going to be doing with home health agencies in our communities includes the following here. Two big things in particular are the promotion of these best practice intervention protocols, which are tools that have been developed by experts around the nation working for the Home Health Quality Improvement program that you'll be hearing more about in the course of our collaboration together. These have been vetted. They're easy to implement. There's also a cardiovascular data registry that we're helping our home health agency partners work with, which is provides a really easy way for them to measure their efforts and any interventions they might implement with regard to cardiac care, especially the ADCs measures. Those of you who are familiar with the home health world are probably aware that CMS has issued a new conditions of participation rule, which went out for review some months ago. I don't know that that's been released yet. It could really come any minute, but a significant feature of the conditions of participation call for a QAPI program, Quality Assurance and Process Improvement Program, as part of working with Medicare and receiving Medicare payments. So we are helping agencies that are brand new to QAPI and have a number of questions about that. These are agencies that are serving the same core. So take a look at this. I think it's particularly striking here. Almost 80% of home health care diagnoses involve heart disease or stroke-related issues. Almost 80, well, a little over 80%. In terms of annual hospital discharges, heart disease is a primary diagnosis. 3.7 million people. Cerebrovascular disease is a primary diagnosis, 1 million. And for ambulatory and ER visits, heart disease as a primary diagnosis constitutes about 14.4 million visits. Stroke, 3.7 million. So certainly our friends in the home health agency world who are part of this larger team are going to be instrumental in the work that we're doing here. Just a couple of quick snapshots of the best practice intervention packages that we can help you implement or help train your staff on these or get you in touch with some of our national folks in HHQI. This is a great sort of ready-to-go PDSA cycle, if you will. So if you're a home health group and you've never done a QAPI program, once you're signed up for the Home Health Cardiovascular Data Registry, where you can actually track your progress, you can implement one of these interventions and see how it affects your health outcomes over time. Super, super easy to do. A lot of people are becoming aware of this, and this is going to be a focus of our work as well. All right, and so finally, this brings us to a discussion of what we want to accomplish here as part of this LAN. So if you're not familiar with that term, that's one that you'll hear going forward with us. That's the Learning and Action Network. Just as the name implies, it is a network of healthcare organizations, of individuals, kind of a Rolodex of interested persons in our 3-state territory who are committed to making changes that improve cardiac health in these underserved communities. And so it's a way for us to really convene those interested parties and exert really, in the long term, what amounts to kind of a collective impact on these issues. And so you can expect monthly programming from us. We anticipate that we will develop other venues in addition to just a webinar, which is pretty one-sided here, that allow you to get in contact with your peers and to exchange information. In fact, that's going to be a key feature of how we operate. While we certainly have our level of expertise in quality improvement, we humbly recognize that we are not the only experts in the room, and one of our goals in implementing the Learning in Action Network is to facilitate your voice and your messaging to your peers using a venue like the Learning in Action Network. So instead of just broadcasting a single message, we really want to treat in an organized way a variety of messages that are kind of grassroots and organic in a way. So a more egalitarian approach to sharing knowledge and learning from one another. And for those of you that are advanced in your quality improvement, this is also an excellent opportunity for you to mentor another organization who might need a little peer support. We have found, as we've asked well-known, high-performing organizations to participate, that they welcome an opportunity because it allows them to take their own learning up to the next level in implementing other folks. So we hope to grow this resource over time. A number of the topics that we anticipate we'll talk about, not surprisingly, all consistent here with our work on cardiac healthcare disparities. Certainly prevention in general will be an important topic. Prevention generally, because cardiac health, of course, overlaps greatly with a number of chronic diseases, namely diabetes, certainly others. Operational strategies that you can implement, so we can help you as a team with workflow analysis and improvement. That's kind of part of that PDSA cycle that I was referring to earlier. And then as far as those system level changes, again, incorporating more of an upstream public health approach to the care that we provide is an important facet of this. Though our goal overall is certainly community betterment with regard to cardiac health, as CMS funded agencies, our central focus has to be on ensuring that older Medicare and dual eligible beneficiaries can sustain their engagement, access to, and understanding of their health care information as well. So that is certainly there. And then finally, again, this is an egalitarian network. Even in our role as a convener, we will be turning to you for topics of importance that relate to cardiac health and reducing healthcare disparities. And so anticipate that we'll be coming to you asking for some ideas, and also asking those of you who are along your QI path to share some of the learnings that you've accumulated in your work with others in the network. And so I think probably at this point, we're about 45 minutes into it, and I just wanted to leave a little bit of time to see if there are questions here. You have in front of you some important state contacts. Now these are sort of 3 points of contact in our respective states. We have Melissa Ottinger in Michigan. Now their team is larger, as is Minnesota's and Wisconsin's, but this is important contact information for you to have going forward. We're always happy to talk, and certainly we'll be reaching out to you proactively as well. So with that, I will invite any questions here. Please put those into chat, and I'll be happy to answer those. See, one of the nice things about using chat is, if you have a mouthful of your lunch right now, you can use your fingers to talk to us. So, and if you don't have any questions today, again, the information, the contacts that you have in front of you, more than happy to answer any questions that you do have that perhaps you didn't want to share with us today. I will have there will be an eval emailed out to those of you that participated today. We just want to get a little bit of feedback from you because we really want this series of programming to represent your interests and your needs. So please don't hesitate to share any of that with us. I'll give folks a couple more minutes here to their thoughts, see if they have anything they want to ask. All right. Well, I know some of you are on your lunch break, and others of you have things that you need to get to. So with that said, I think we'll go ahead and end our call a little bit early, so give good time for all of you. But please look out for that evaluation. And again, please don't hesitate to call me in Wisconsin or Jerry in Minnesota or Melissa in Michigan if you have questions. And we'll be happy to help you with those. That said, we're going to be developing a calendar with all of these programmings coming up, and we'll make sure that you have access to that as well. So with that, I'll go ahead and sign off. Thanks, everyone, for joining today, and we'll talk to you soon again. Thank you.